Anaphylactic Shock.
Student Nurse! So I'm going to be covering the pathophysiology of anaphylaxis. Anaphylaxis is a severe, acute, life-threatening systemic hypersensitivity reaction caused by the sudden and overwhelming release of histamine and other chemical mediators into circulation. Most anaphylaxis reactions are immunologic, using the IgE antibody, but some much less common forms of anaphylaxis use IgG or are even non-immunologic. But we're going to be talking about the IgE-mediated one. So how it happens is people are sensitized inappropriately to an allergen, and that can be, well, we'll go over that in risk factors. But what happens is a dendritic cell engulfs the antigen, which I have here in the red A, and it presents a bit of the antigen to the T cells. T cells are then activated to release cytokines, which are communication molecules that bring the B cells close to the area. B cells are then, they basically release IgE antibodies, and those antibodies attach to mast cells and basophils, which are granulocytes. So then on the second exposure to the same antigen, we have the little bits of antigen coming, and what happens is they just go directly and attach and make an immune complex with that IgE antibody that's on the mast cells and basophils. And what that does is it stimulates the granulocytes to release their granules, and those granules are mostly histamine, but we also have cytokines and leukotrienes and other chemical messengers. So what happens is that histamine comes out and it attracts more mast cells and basophils to the area, and those degranulate, and all these chemical mediators start going into circulation all around the body, attracting more and more mast cells and basophils to degranulate. And before you know it, the body is overwhelmed with huge quantities of histamine, cytokines, and other chemical mediators. What effect does that have on our body? So histamine has a lot of serious effects on our body. First and foremost, it causes smooth muscle contraction in the bronchi and the GI tract. So what happens is your bronchi and bronchioles contract, which of course reduces the airway. In the GI tract, it contracts the smooth muscle, it causes GI upset, so it will cause the person to feel abdominal cramping, nausea, vomiting, and maybe even have some diarrhea. In the circulatory system, histamine causes peripheral vasodilation and increased permeability of the blood vessels. So what that means is your systemic volume is basically starts leaking out of the blood vessels throughout the whole systemic circulatory system. And so you have a lot of buildup of interstitial fluid, which is going to look like swelling and edema. And you're actually then going to end up having hypovolemia within your circulatory system. And so what happens is the heart tries to compensate by beating faster and trying to keep that blood pressure up because of that lack of fluid that's there. So what we have is basically systemic complications. So in the cardiac system, we have decreased blood pressure because of that hypovolemia, tachycardia, which is the heart's response to that hypovolemia. It's trying to increase the cardiac output by increasing the heart rate. Myocardial ischemia can be from the lack of oxygen that's getting into the blood in the first place, because don't forget we have that bronchoconstriction, so we have less oxygen going in, and so the heart's not getting oxygenated properly, but also due to that decreased cardiac output, we also just don't have a lot of blood going to nourish that heart muscle. So we might end up with some myocardial ischemia, which could even progress to myocardial infarction. We'll have dysrhythmias because everything's just kind of getting thrown out of whack in the cardiac system. Again, decreased cardiac output. We're going to have peripheral edema because of the vasodilation and increased permeability. And we could very well end up with end organ damage if this is allowed to go on because of that decreased oxygen to the tissues. So with the pulmonary system, again, you're going to see that bronchospasm. And we're going to see pulmonary edema because of that third spacing or the fluid shifting out of the blood vessels and into the lungs. We're going to have airway edema, so your larynx is going to swell up, your tongue is going to swell up, and again, that's going to compromise air entry into the body. resulting in hypoxia, so just an overall decrease in oxygen, and eventual respiratory failure as the person tries to compensate and breathes faster and tries to use those accessory muscles to really try to get that air in. Eventually they're going to run out of energy, particularly since our tissues don't have enough oxygen to maintain that high or increased muscular demand. In the neural system, we're going to end up with cerebral hypoxia, of course, and possibly cerebral edema too, just because of that increased permeability of the blood vessels up in the brain as well. In the GI, we talked about cramping and abdominal pain, nausea, vomiting, and diarrhea. Again, that's because of that smooth muscle contraction that happens due to the histamine reaction. And in our skin, we're going to have localized swelling, so pruritus and urticaria, and we're also going to have angioedema, so that's like just general overall swelling that you're going to notice all over the body, and erythema, so areas of redness, and that can usually starts happening up in the chest area, but it can happen anywhere in the body. Along with histamine, we also have the release of other chemical mediators. Tryptase and platelet activating factor are two notable ones, and they participate in the coagulation cascade actually, and so what that does is it stimulates the coagulation all over the body, and that can result in disseminated intravascular coagulation, which is a really dangerous complicating factor which can result in bleeding and clotting all throughout the body.
Okay, now we're going to go over signs and symptoms again. Katie did a brief overview, so now we're going to go into it a little bit more in depth. As we know, histamine is going to cause all of our problems, and what does that mean for all of our systems in our body? Well, our respiratory system is going to show these signs of dyspnea, swelling in the upper airways, tightness in the throat, hard to swallow, unable or trouble speaking, coughing, watery eyes, stuffy nose, and why is that happening? Well, histamine is going to cause vasodilation in the body. It's going to increase permeability in the body, which is going to cause the swelling because all the tissue and fluid is leaking into the outside of the vessels into the interstitial spaces. So you're going to get swelling in the neck, could cause dyspnea. And then for cardiac, we're going to have a decrease in blood pressure because of the vasodilation from all of the histamine release. That's going to cause hypotension. We could potentially have arrhythmias, can become confused or loss of consciousness, and that is due to the vasodilation getting less blood to the brain and O2 to the brain. You can become lightheaded, dizzy. You can also be tachycardic, so increased heart rate, and you could have potential chest pain. For the GI system, with the decreased or increased secretions of the GI system, it can cause nausea, vomiting, abdominal pain. Okay, and the skin, you're probably going to see hives, red, itchy skin, like flushing, swelling of the throat, face, tongue, and eyes. Those can be signs of an anaphylactic shock, and that is also from the vasodilation, and the histamine release is going to cause all those things. Neuro, so again, we talked about the confused or loss of consciousness, sense of impending doom. Lots of patients will feel like this is it for them. They're not going to make it.
So for this section, we're going to talk about the emergency response, what you do and what it looks like. So to start, I just want to draw attention to our response kits. So all response kits will have a DST protocol, 4 ampules of epinephrine at the correct dosage, so 1 milligram per mil. Then we'll have 1 mil syringes, usually about 4, 1-inch needles, half-inch needles, 25 to 27 gauge. And then lastly, you'll have your alcohol swabs. So with these kits, we need to watch out and make sure that the epinephrine isn't expired. It's important to remember that even though it's an emergency situation, we're still doing our rights and we're double checking that it's the right med, right dose, and that it's not expired for the right person. If the client does have their own EpiPen and your anaphylaxis kit isn't readily available, you are able to administer their EpiPen, noting though that it's only 1 dose. So EpiPen, orange to the thigh, blue to the sky. Making sure again that it's not expired. So dosing, there is a dose by age protocol. So you can see there it's pretty broken up, but for the point of our practicum and the point of the presentation, we're gonna go with adults. So adults are anybody 14 and older, and their dose is 0.5 milligrams at 1 milligram per mil. So if it isn't an adult, it's less than 14, or if your adult is 16, 17, even 30, but really petite, you're gonna wanna go by weight if you have a recent weight. So if you're going by weight, you're gonna go 0.01 milligrams per kilogram to a max of 0.5. So lastly, before moving on to what we're going to do in emergency protocol, we just want to mention that Benadryl has been removed from the anaphylaxis kits as well as off of the Northern Health's anaphylaxis protocol. We've done this because it's an emergent situation and Benadryl has no effect on the cardiovascular or respiratory system, and it also affects sedation. So LOC is a really big thing that we monitor during an anaphylaxis protocol, so we just want to make sure that there's no other factors coming in and wrecking that for us. Okay, so now we're going to talk about the emergency treatment. So this is per Northern Health's anaphylaxis protocol. So wherever you're going to a different health authority, you're going to have to double check and make sure it's similar, or just double check your protocol. So we just want to disclose before we go into this, if you do give somebody epi and they aren't in anaphylaxis, it does not harm them enough that you should hold it. So always initiate the protocol if you believe it's fit and go from there. So initially you're going to assess your client for signs and symptoms. So the three cardinals that we're looking for are your airway, breathing, and circulation. Their skin, any changes, rashes, urticaria, or bruising. We're going to look at their mental status changes. Have they decreased the LOC? Have they become lethargic or confused? Or do they feel like they're impending doom? So after we've assessed the signs and symptoms, we're going to move into removing and stopping the offending agent. We want to stop this causative agent because we're basically adding fuel to the fire if we keep whatever is causing it going. So we're going to stop it. So next we're going to administer our epinephrine. So we're giving epinephrine 1 milligram per mil, 0.5 milligrams for adults over 14, otherwise we're going weight-based. So we're giving this epi and we're giving it IM and we're giving it into the vastus lateralis, so their leg. If per se they got an IM injection of a medication or their IV was in a certain arm and that was what caused the anaphylaxis, we're gonna give the epinephrine in the opposite leg. Right IV, left leg, okay? So by giving this epinephrine, we are acting on beta 1 adrenergics as well as beta 2 adrenergics. So beta 2 is your lungs. So by giving this epi, we're causing bronchodilation and we're controlling the bronchospasms that we're having. This increases the amount of O2 we're getting into our lungs and helps with our decreased oxygen that we talked about previously. So epi also inhibits the histamine from the mast cells in the lungs. So this helps decrease the amount of capillary permeability. So it decreases the blood that's pooling in the lungs, it decreases the secretions that is pooling, and it helps limit the risk for pulmonary edema associated with our histamine. Additionally, it works on the heart. So these are the beta 1s. And by doing that, we have a vasopressor response. So it's going to increase your heart rate, it's going to increase your contractility, and therefore increase your stroke volume. So we refer to the increased heart rate, the increased contractility as vasoconstriction. The vasoconstriction helps with increasing your cardiac output. So by affecting beta 1s, we're also increasing the cardiac output, tissue perfusion, and impaired gas exchange from the beta 2s. So by giving epi alone, we're taking care of our nursing diagnoses of decreased cardiac output, decreased tissue perfusion, impaired gas exchange, and the depleting O2. So after we give epi, we're gonna call a code blue and we're gonna get help. While code blue is on their way, we're reassessing the airway, breathing, and circulation. Are they still having symptoms? Did the epi help with tissue perfusion? We're checking the cap refills and such. Then we're gonna move into placing the client into the recumbent position and we're gonna elevate the legs, okay? We're gonna administer O2 to help with hypoxia prevention, and we're going to try and keep the SpO2 over 92%. So by giving the oxygen, again, we're helping with gas exchange. We're giving more oxygen to the body, and we're trying to prevent that hypoxia and that buildup. We're gonna do continuous observation. So Q5 minutes, we're running vital signs. We're running a full set of vital signs, including capillary refill checks, checking for tissue perfusion. We're checking to see if they have cyanosis anywhere or if, again, the symptoms are persisting. If the symptoms are persisting, we're going to repeat epinephrine Q5 minutes. So you can do this 2 times. to have a max of 3 doses of epi. Once you reach that max of epi, continuous monitoring until the code team comes. We're going to, once we've given that, we're going to try and get an IV access. So with an IV access, we're trying to give them fluids. We want to correct their fluid imbalances. We want to, if it was an IV blood product or an IV med, we want to try and dilute the med, and we want to decrease the amount of histamines within the body. And then we're going to document and hand over to the code team. So with this handover, they need to know what interventions we did. So they want to know, did we give epi? Did we give O2? Have we been doing our vital signs? Have they been stable? Have they been showing that they're working or not? We want to look at if we've got them in the right position and if we stopped the agent right away. We're going to talk about the time it started and how long it's been since it started, if you're good at math. And then we're going to talk about the symptoms they presented with. So did they have all of the cardinal symptoms, or did they have kind of funkier ones that we don't usually see, or did they have all of them under the sun? Was it a really bad initial reaction? And then we want to talk about the response to treatments. So did they respond to the first shot of epi, or did they need 2 or 3? Did they respond to the O2 administration? Did we need to use a mask? Did we have to have 15 liters? Did we have to have 3? We want to talk about what we did and how it affected the person and how they are the way they are currently presenting for the code team.
Okay, now we're going to go into lab and diagnostics. So we want to check the ABGs. These patients can be very acidotic as they're retaining lots of CO2 because they can't blow off the CO2. So you might see respiratory acidosis, metabolic acidosis, and those can be very dangerous for our patients. Lactate, we want to check the lactate. If it's increased after a prolonged period of time, they can go into a secondary reaction. So we just want to be monitoring these lab values to make sure that we're keeping up the line and everything. D-dimer, as Katie said earlier, there can be an increased coagulation. Clotting, we want to be checking the D-dimer continuously as a nursing intervention. Tryptase is an enzyme that's released same with histamine. That can be checked 1 to 2 hours after to prove that it was an anaphylactic reaction, as this will be increased with anaphylaxis. Same with histamine. Say this patient we didn't know has never had an allergic reaction before, you're going to want to do an allergen serum testing. You probably want to book that for them if we don't know what happened or what they took. 24-hour urinalysis, this can also be to check more of these things, and also just to check the kidney function because their kidneys might not have been perfused as long and they could have some kidney damage. ECG, as we know, they're not getting enough oxygen to the heart. The heart can have some sort of arrhythmia. We want to be checking to make sure that they're not going to have any ischemia in the heart. Okay, so now we're going to talk about our nursing diagnoses related to anaphylactic shock. So we could see ineffective breathing pattern related to bronchoconstriction, airway edema, and pulmonary edema. This could be as evidenced by shortness of breath, coughing, unable to speak, or using 1 to 2 words in their sentences. And we could also see decreased cardiac output related to increased capillary permeability and vasodilation. So with that, you can see an increased heart rate, decreased BP, and also with the heart rate, it could eventually decrease because we have less cardiac output going out. We could also see 30 pulse, and we want to check the cap refills. We have a slower cap refill. Those can all be signs of a decreased cardiac output. Also have at risk for decreased tissue perfusion related to hypoxia and decreased cardiac output. With this could be as evidenced by decreased urine output, check their temperature. They could be cyanotic, cool skin. Their cap refill could be slower. And the pulse could be steady as well with the increased heart rate and decreased cardiac output. Secondary nursing diagnoses that we would also like to include but are not really ending are deficient knowledge, risk for PTSD and anxiety, risk for unstable blood glucose levels, risk for end organ damage, risk for clots, DVT, pulmonary embolisms, bleeding, impaired skin integrity, and risk for impaired gas exchange.
Okay, so with these diagnoses and keeping in mind that your patient might be a little more stable now, this is after the first anaphylactic shock. So we're going to continue to monitor our patient because although they might be more stable, they're still at risk for lots of these, as well as rebound anaphylactic shock. So we want to be continuing monitoring, continue to take your vitals. We want to be educating our patient and helping with anxiety, making sure that they're getting the proper amount of oxygen and not hyperventilating. And we also want to be checking our ins and outs, like Ashley said, watching for end organ damage, we want to make sure that our kidneys are working well. So also continuing to taking the lab and diagnostics we talked about earlier, just for watching for any signs of any kind of organ damage. Okay, so we also want to be checking our neurologic status. As Ashley said, we don't know exactly how much oxygen the brain is getting or if there was any damage during the initial anaphylactic shock. We also want to be making sure that our patient isn't partaking in too much activity right now. They need to be resting. They need to be in a calm and quiet environment. So making sure, dimming the lights in their room, making sure, if possible, the door's closed so that they're not getting too much sound from outside going on. We also want to take some comfort measures for them. So if they do have a lot of pruritus, we want to try to help with that itchiness, whether it's medication or non-pharmacological. And then we just want to be encouraging them to taking deep breaths and coughing as well, because we want to make sure that they're getting enough oxygen. Okay, so I'm going to be talking about causative factors. So first off, with anaphylactic shock, there's lots of things that can lead to it. One of the most common being various food products, so things like nuts, eggs, shellfish, dairy. The other thing is medications, which is also commonly seen in the hospital. So things such as like vaccines, IV antibiotics, lots of different things. You just have to kind of be aware of what you're giving your patient so that you know what it might be. And then IV contrast as well. When getting a CT or like an MRI, a lot of people are allergic to the dye, so it's very important to make sure with your patient whether or not they are allergic to that. Another thing is various insects, so of course you have your bees, you have wasps, another one is actually fire ants. And then you have latex gloves, lots of people are allergic to latex. And then you have exercise-induced anaphylaxis. So this anaphylaxis is actually still being very much looked into because they're not aware really of how the patho for it actually works. So there's still a lot of research being done into it, but you could even just be going for a stroll sometimes, and some people do suddenly go into anaphylactic shock. Another one is blood products, so things like your packed red blood cells, platelets, all that kind of stuff you need to watch out for when you're giving your patient, which is why they have the protocol in place of monitoring your patient right away and taking their vitals before and after, and then waiting with them for 15 minutes. Okay, so next I'm going to be talking about risk factors. So there are lots of different risk factors for anaphylaxis, but the main ones being asthma. And the other thing with asthma too is it does increase your risk, but if you actually get anaphylactic shock and have asthma, you're also at a higher risk for more damage because of your airway constricting. Another one is allergies. So obviously, like explained in the pathos, for some allergies, the second exposure to that allergen makes it worse. So that's a risk factor. Another one is previous history of anaphylaxis. Okay, so another risk factor is other conditions such as heart disease, because your body actually has an increased amount of toxic cardiac mast cells because of your heart disease. And this puts you at increased risk because of all the extra mast cells in your body. And if you actually develop anaphylaxis with heart disease, you are at an increased risk of developing permanent damage because the medications that you take if you have heart disease, such as beta blockers, actually reduce the effects of epinephrine.
Going to be discussing anaphylaxis prevention because as nurses and as patients and as people out in the community, we need to know how can we prevent this from happening. So the first thing is we should know as nurses our anaphylactic clinical practice standard, and we should also know our safe medication administration practices, and you can get those on our NH, and the two numbers are up there for you to look at. As per the clinical practice standard, it is our responsibility to take the My Learning Hub module. So that's the anaphylaxis module there. So we need to be taking that as part of our practice. Number 3, when a patient is admitted to the hospital, ask them about their allergy status and with any side effects and identify those triggers. Number 4, when we're going to be starting a new medication, give them the education about the anaphylactic side effects, and that if they don't understand you, get the family involved. Maybe they can help translate it in a way that's meaningful to them. Number 5, your patient ID. Make sure they have an ID band on, and if they have an allergy, to make sure that it's the red band. And also looking for tattoos that say that they have an allergy status, or if they have a medical alert bracelet. Number 6, we want to highlight the allergies on the MAR just to bring it to our attention, because our days are busy and medications, especially in the morning, like we have to snap them out. So just highlighting those, especially on night shift, will help the next shift coming on. Number 7, know where the anaphylaxis kit is and the crash cart. We want to make and do that every shift, because we don't know if the crash cart has been used and it needs to be updated, or if the anaphylaxis kit is expired or it's been used. We're going to want to be on top of that at the beginning of our shift. Number 8, we're going to talk to our patients about any dietary restrictions. And then if they do have any updated restrictions, we're going to want to update their dietary Cardex. Number 9, we are recommending a skin allergy test when you're out in the community. Maybe get that test, see the allergist, just to kind of narrow down. Number 10, if someone does have a bee sting or a wasp, or if they've been hit by a hornet or a red ant, you're going to want to scrape the skin. You don't want to squeeze the skin, and then apply ice to the area. Number 11, latex allergies. So we can find latex on the rubber vials of insulin ampules, Foley catheters. We want to make sure they're no latex. Using non-latex gloves, and if patients are using condoms or diaphragms, make sure they don't have any latex in them. As well as blood pressure cuffs. If someone might have latex, you might want to just wrap like a cloth around it just to protect the skin. Number 12, so as per our Code Blue protocol, we need to know that it is an actual Code Blue. We're not here to work by ourselves. We need to get the team on board. So pressing that button will just help get the patient stabilized better. And lastly, for the blood transfusion, know the DST and make sure you have your emergency equipment available at all times before you start the infusion.
Dealing with anaphylaxis and the anaphylaxis protocol in emergency situations is a team effort, and it requires a team in order to prevent secondary anaphylactic shock.
Thanks for listening to our video.
Bye, y'all!
I saw you guys looking away. Pausing.